So we're recording right now. Don't
Okay.
worry about it.
Okay.
Just make sure you
All right.
pause before you start or
Okay.
stop.
All right. All
And
right.
you should
No
be
problem.
in good shape. I will
Okay.
close my door.
Thank you, sir.
All right. And
I'll
make
come get
sure-
you.
Let me make sure it's running. Yeah, it is. Okay.
All right. Thanks. Hello, my name is Tom Voyles, and I am an assistant nursing professor at Mercy College in the ASN program. I am also a clinical instructor in the ASN and BSN programs at St. Vincent Mercy Medical Center. I want to thank Dr. Pauly for asking me to talk to you today about quality and safety at the unit level in the hospital setting. I've been a registered nurse for 32 years. I graduated from the former Mercy School of Nursing in 1985. I have worked in a variety of settings at St. Vincent, including the neurointensive care unit, the medical, surgical, and trauma intensive care units, the critical care flow pool, the emergency room, and in a 3-year stint in 2011 through 2014, I was a unit manager for the 4B unit at St. Vincent, which is the ICU step-down, and the 4C unit at St. Vincent, which is the oncology and pulmonary unit. I was asked to speak to you today to offer a management perspective on my role in addressing patient quality and safety as a unit manager from St. Vincent Mercy Medical Center. I was able to read over your PowerPoint on quality control and read chapter 23 from your management book. My plan is to talk to you about different quality improvement programs that I instituted on my units to give you a good example of the content learned from you in those chapters. I would like to start out by mentioning several terms that are synonymous with quality control. They are terms like performance improvement initiatives, quality management, performance management processes, quality outcome management, quality assurance. You'll hear all of those terms mentioned. They all basically mean quality control. At St. Vincent, we refer to quality control as QoS, or Quality Operating Systems. Your book talks about TQM, or Total Quality Management, as a form of quality control. What does quality control mean to me and to all of you? These are so-called buzzwords, basically mean the same thing. We are always looking at ways to improve patient safety in our hospitals. Why? Why are we so concerned about patient safety? It's because we must answer to and demonstrate accountability to our insurance companies, the government, which includes Medicare and Medicaid, the Joint Commission, and most importantly, to our patients that we care for. As a manager of a couple units at St. Vincent, I had several performance improvement projects going on to improve patient care. I participated in the Institute of Healthcare Improvement, the IHI, seminar in Cincinnati in 2011. It was a 5-day seminar in which we were in class 5 days to learn about quality operating systems, quality management, and performance improvement projects. From this seminar, I was able to bring this teaching back to the hospital and put principals to work in developing these performance improvement initiatives. You see, according to the Institute of Health and the Institute of Medicine, approximately 75,000 patients a year die from preventable errors in our hospitals. It is our job as nurses in the hospital to keep patients safe. We do this by participating in these performance improvement projects. Preventable errors are also called never events or adverse events. Examples of never events or adverse events include deep vein thromboses that occur as a result of being hospitalized, falls that occur in patient rooms, in patient hallways, bloodstream infections, CLABSIs, or central line associated bloodstream infections, CAUTIs, or catheter associated urinary tract infections, and post-operative infections that happen as a result of surgery. Also, a never event is when a patient is readmitted because we as a hospital did not provide accurate or good discharge instructions to these patients to be able to take care of themselves at home. Let me first talk about the core principles of quality improvement. 1. QI is using data and feedback for improvement. The data is collected, analyzed, and monitored. It is never judgmental. In other words, nurses are not punished because a never event happened as a result of their care to one of their patients. All of this data is used as feedback to improve care and to improve patient safety. Quality improvement empowers staff to be involved. An example of empowerment of nurses is this. Let's say one of the physicians walks in and tells you to get the patient ready for a femoral line insertion. In other words, the doctor wants to put a central line in the person's femoral vein. It is well known that bacteria is colonized and is very rampant down in the groin area, and that a better place to put a central line would be into the neck or into the subclavian vein up here in the chest. So we are empowered in letting the physician know that it is a better choice to use the alternative sites and not use the groin, because a bloodstream infection can result if a central line is placed in the femoral vein. That is an example of a nurse being empowered in telling a physician that you are concerned about patient safety. A second example is what we are currently involved in the hospital now, and that is Foley insertions and Foley length of time, the length of time that a Foley stays in a patient. Right now we are in the process that 24 hours following a surgical procedure, the Foley must come out. But it must be ordered by a physician. So nurses are continuously calling physicians or letting them know when they make rounds that, hey doc, can I please get that Foley out of that patient, because we do not want that patient to get a urinary tract infection. The longer the Foley stays in the patient, the higher the chance that the patient can get a urinary tract infection. So let's talk about QI and how it benefits, why it is beneficial in the hospital. QI improves patient satisfaction as well as staff morale. Remember that patient quality can be defined, measured, and most importantly, improved upon. So how do we improve patient quality? We must answer 3 fundamental questions. What are we going to improve, and by how much? That is the first question. The second question is, what is doable? In other words, how will you know that changes that you are making is making an improvement? This is simply called a document of change. What is the model of improvement going to be? That is the third question. What changes can we make that will lead to improvement? This is where we create what we call a PDSA cycle. I'm sure you've heard of that before. The P stands for planning the test. The D stands for doing the test. The S stands for studying the results. And the A stands for acting on the results. Now I will apply an example of a performance improvement project that a team of us developed at the IHI in Cincinnati and brought back with us to St. Vincent to be employed on the Unit 4B that I managed. What we knew at St. Vincent at that time was that all patients that are admitted to the hospital are at risk of developing a DVT. because when patients are sick, they are sedentary, and many of them are on bed rest because of that. We knew that in 2011, there were 180 patients at St. Vincent that developed a DVT as a result of their hospitalization. Several of these patients developed pulmonary embolism, and most had to stay in the hospital for additional days as a result of developing that DVT because of anticoagulation that had to be started. So we answered the first question. We wanted to improve patient care by decreasing our DVT rate in 2012. So answering the second question was we proposed a change that was doable. We figured that if we can get the physician to address DVT prophylaxis on every patient that is admitted to 4B, this would decrease the number of DVTs among all patients admitted to the hospital. This was, of course, based on evidence-based research that was already out there. If this test worked, it would spread to the other units in the hospital, where the test would be employed on all patients admitted to the hospital. The test of change was initiated, and the test was monitored on 4B for 1 month. The test was this. The RN, when calling for orders for all admitted patients, would simply ask the physician, "Doctor, may we address DVT prophylaxis?" and start the patient on Lovenox 40 milligrams sub-Q, and also start the patients on mechanical prophylaxis, which consisted of placing EPC cuffs on the patient. That was the test. That was the only questions that we asked the physician at that time. Most physicians, in fact 96% of the physicians, agreed upon this. We had to make sure that the patient did not have any contraindications to DVT prophylaxis, like a thrombophlebitis or a patient that had some type of leukemia or that had a bleeding problem in the past. But as long as that patient did not have any of these contraindications, then we would get this order from these physicians so that our patients would be safer. The test was a success as a result. All patients that were admitted to 4B were on DVT prophylaxis. This was shown through weekly audits that were performed by my excellent staff that were on board with this initiative. In 2012, the DVT rate was decreased to 48 from 180 the year before. This performance improvement was proven to be a success. The key with any performance improvement project is the support that the staff provides you during your project. Another example of a PI project that was started on 4C, the oncology unit that I managed, was when I was the manager of that unit. We had 4 cases of bloodstream infection in our oncology patients that were receiving chemotherapy. So in a 1 month period of time, there were 4 bloodstream infections in our patients. I was asked by the quality office at St. Vincent to do something about this. They wanted me to improve this rate. This rate was too high. So the staff and I came up with a project that we hoped would decrease these bloodstream infections from happening. So our test of change was 2 things. We decided that we were going to do a sterile dressing change every Monday and Thursday on these PICC lines. And these dressing changes were going to be done by a certain number of dedicated staff, oncology nurses, that took care of these patients. The second thing we decided to do was not to draw blood off of these PICC lines unless authorized and ordered by the physician. In other words, through evidence-based research, it has been proven that drawing off of a central line, drawing off of an IV, or drawing off of a PICC line, that is drawing blood off of that line for lab, okay, has proven to cause bloodstream infections. So what we decided to do was we decided to stop drawing off these lines and poke the patient with a needle, and this would be done by laboratory. This would not be done by the nurses anymore. As a result of this change, as a result of doing this performance improvement project, 4C did not have any bloodstream infections for 18 months after this project was initiated. I had to report all of these findings in weekly QoS meetings with hospital directors and CEOs that came to my unit to learn from us and to learn what we were doing to improve patient safety. What was important was progress was seen. I want to talk briefly about with you sentinel events and root cause analysis, and you'll see this in your PowerPoint as well. An RCA, or a root cause analysis, is just a meeting of staff members involved in a sentinel event. And what the aim of a root cause analysis is to find out exactly what went wrong and how do we improve upon this so that it does not happen again. For an example, on one of my units, I came in on a Monday morning and my staff immediately came into the office and told me that one of our patients fell during the night, bumped their head on the end table, and developed a subdural hematoma, in which this patient had to go to surgery immediately and was in neurointensive care for a couple days following the incident. So what we did was the quality management office at St. Vincent ordered a root cause analysis in which we got together the nurse, the charge nurse that night on the unit, the nurse taking care of the patient, and myself got together with quality management to discuss what happened, why it happened, and what we could do to prevent this from happening again. That was a root cause analysis. No blame was ever set. No blame was ever brought upon the nurse taking care of that patient. Joint Commission, of course, requires these root cause analysis to be done on any sentinel event in the hospital. Sentinel events also include any patient that dies as a result of a surgical procedure or a fall or a bloodstream infection. This patient that we had that developed a subdural hematoma did not die, but they did suffer a longer hospital stay as a result of this. One last thing I want to talk to you about is why we must remain accountable and keep our patients safe in the hospital. It is simply because we will not get paid by the government if we do not have performance improvement projects in place. For an example, 50% of our patients that we take care of in the hospital are insured by Medicare. And this means their hospital bill is paid by the government. For each patient that we take care of, the government or Medicare will hold back a certain percentage of the money that is owed to the hospital as a result of taking care of one of their patients. If we do not meet quality metrics that are set forth by the hospital and the government, then Medicare or the government keeps this percentage of money at the end of the year. If we meet our metrics, okay, then that money is paid out to the hospital on a yearly basis. This money is in the millions and millions of dollars. Now you know why it is important to the hospital administration that quality improvement programs are started and followed through to improve patient quality and safety. An example of this would be what we talked about earlier on 4C, patients that have bloodstream infections as a result of us manipulating their lines and as a result of instituting chemotherapy through these lines. The blame from the government is on the hospital. And if the patient has to stay 3 or 4 extra days to get antibiotics because of the bloodstream infection that we gave them, okay, that money, okay, is held. That money is held back. That money is not paid back to the hospital as a result of that 3 or 4 extra days that the patient spends in the hospital. So you can see why administration of the hospital must be on board with all of this. I want to thank Dr. Dan French for his assistance in providing this video today for all of you. I hope that I was able to simplify quality control by giving you real-life examples on how performance improvements projects are started, maintained, and followed through in the hospital setting, and why we do them in the first place. I thank you. It was a pleasure sharing this video with you and information with you today. Thank you very much.